Systemic lupus erythematous. What is systemic lupus erythematous or SLE? SLE is the most common multi-system connective tissue disease. It is characterized by a wide variety of clinical features and a diverse spectrum of autoantibody production. Diagnostic criteria of SLE. Revised American Rheumatism Association ARA criteria are: if a person has SLE, then any 4 out of the following 11 features are present serially or simultaneously. The features are malar or butterfly rash, which is fixed erythema, flat or raised, sparing the nasolabial fold. There may be discoid rash, which means erythematous raised patches with adherent keratotic scarring and follicular plugging. Photosensitivity, which means rash occurs as a result of unusual reaction to the sunlight. Oral ulcers may be seen, which means oral or nasopharyngeal ulceration, which may be painless. Arthritis may occur, which means non-erosive, involving 2 or more peripheral joints. Serositis, which means pleuritis, convincing history of pleuritic pain or rub or pleural effusion. Or pericarditis, rub, ECG evidence of effusion. Renal disorder such as persistent proteinuria more than 0.5 gram per day or cellular casts, red cell, granular or tubular, may be present. Neurological disorders such as seizures or psychosis in the absence of offending drugs or metabolic derangement may be present. Then hematological disorders such as hemolytic anemia or leukopenia less than 2 into 10 to the power 9 per liter, or lymphopenia less than 1 into 10 to the power 9 per liter, or thrombocytopenia less than 100 into 10 to the power 9 per liter in absence of offending drugs. Immunological disorder such as anti-DNA antibodies or antibodies in abnormal titer, or the presence of antibody to SM antigen or positive antiphospholipid antibodies. Anti-nuclear antibody ANA disorders such as abnormal titer of ANA by immunofluorescence may be present. Clinical features of SLE. Sex, around 90% are female. Male is to female ratio is 1:9. Age, peak onset in the second and third decades of life. Musculoskeletal features are migratory arthralgia, morning stiffness or tenosynovitis, and small joint synovitis may be present. The musculocutaneous features are butterfly facial rash, subacute cutaneous lupus erythematous. SCLE rashes are migratory, non-scarring, and either papulosquamous or psoriaform or annular. Discoid rash, erythema, and vasculitis may be present. The renal features are hematuria, proteinuria, and casts in urine may be present. And cardiopulmonary features are chest pain from pleurisy, pericarditis, and myocarditis. CNS features are fatigue, headache, poor concentration, then hallucination, chorea, organic psychosis, transverse myelitis, lymphocytic meningitis may be present. Hematological features are features of hemolytic anemia, neutropenia, lymphopenia, and thrombocytopenia. Other manifestations are fever, weight loss, mild lymphadenopathy, abdominal pain, and Raynaud's phenomenon. The following investigations are done to diagnose SLE. Complete blood count with ESR is done, which show raised ESR, low hemoglobin percentage, and neutropenia, lymphopenia, or thrombocytopenia. C-reactive protein is usually normal, but it is elevated in serositis or infection. In urine routine microscopic examination, RBC, proteinuria, cast may be seen, and in serum complement level, C3 and C4 level are decreased in active disease. Autoantibodies such as anti-nuclear antibody is found. If it is negative, then it is very unlikely to have SLE unless their extractable nuclear antigen are positive. Anti-double strand DNA antibodies occur in only 30 to 50% of patients. Anti-phospholipid antibody may also be found. The treatment options are one therapeutic goal is giving education to the patient about the nature of the disease, then control of symptoms, and prevention of organ damage and maintenance of normal function. The patient has to avoid sun and UV light exposure. He has to use sunblocks. In mild to moderate disease, analgesics and NSAIDs are given for joint pain. Hydroxychloroquine and glucocorticoid and other immunosuppressants are given if necessary. In severe and life-threatening disease, high-dose corticosteroid and immunosuppressants are used. The commonly used regimen is pulsed methylprednisolone 10 mg per kg IV plus cyclophosphamide 15 mg per kg IV repeated at 2 to 3 weeks interval for 6 cycles. The maintenance therapy is following control of acute phase. Typical maintenance regimen is oral prednisolone in a dose of 40 to 60 mg daily, gradually reducing to 10 to 15 mg per day or less by 3 months. Azathioprine, methotrexate, or mycophenolate mofetil should be also prescribed. In patients with SLE and the antiphospholipid antibody syndrome who have had previous thrombosis, they require lifelong warfarin therapy. What is the difference between rheumatoid arthritis and SLE? In rheumatoid arthritis, in SLE, malar rash, discoid rash, photosensitivity is present, but in rheumatoid arthritis, this malar rash, discoid rash, and photosensitivity is absent. In SLE, oral ulcer, renal involvement, and CNS involvement like seizure psychosis may be present, but in rheumatoid arthritis, this oral ulcer, renal involvement, and CNS involvement is absent. In rheumatoid arthritis, rheumatoid nodule, ocular involvement, And joint deformity such as swan neck deformity, boutonniere deformity and Z deformity may be present, but in SLE they are absent.